Bismillahirrahmanirrahim. My case would be an interactive presentation, so I would like you to interact during my presentation. Bismillahirrahmanirrahim. My patient is a 45-year-old lady who was diabetic and hypertensive, and she presented with chest pain, shortness of breath, and hypotension. And there was history of splenectomy due to accidental surgery in the past. And on ECG, there was ST elevation MI, anti-wall ST elevation MI. Troponins were elevated. And there was severe hypokinesis on echocardiogram with poor LV systolic function. So she underwent coronary angiography. And these are the first views of the coronary angiography. The left system was not engaged and non-selective injection didn't show anything. Now I would like somebody to help me in reading this angiogram. Will somebody from the panelists or from the audience like to comment on this angiogram? Yes, somebody is saying mega dominant RCA. What else? What about the left system? Are you able to visualize the left system to some extent in this?
The left system is also rising from the left side.
You think that left system is also arising from the right system? And can you see the origin of the left system from the right on this angiogram?
The origin can't be seen.
Origin can't be seen. So what should you do about this patient? What next? How do you interpret this case? Overall, what is the interpretation of this case?
Could be the intra-arterial course of the left system.
Yes, you think that it could be inter-arterial course of the left system. Any other possibility?
Why could not be this?
Maybe the left main stem was occluded, maybe something else, I don't know. Do you have any other suggestion? Sorry?
Interarterial है कि नहीं बताना difficult होगा I think.
Okay, one of the possibility is the interarterial course. Okay. So anyway, the mystery was not resolved here, so we opted for a cardiac CT to resolve the mystery of this case. Anyway, this is the cardiac CT of the patient. Now again, I would like somebody to help me in reading this cardiac CT. Anybody from the panelists or from the...
Dr. Parveen is like to comment.
Okay. Please, Tipusa, please comment.
Yeah, the first vision I said that system was pretty good. My class is going into the PRP and it was filled by the RCA. And the RCA was right already was.
Sorry, say it loud, but whoever want to say something, say it loud.
It's also showing that the left main is arising from the MPA. And there is an extensive collapse with the RPA, between the RCA and the nerve system, and there is a pulmonary policy.
So where is the MPA? So
I think मैं repeat कर देता हूँ. Dr. Parveen ने कहा है कि जो है ना left system left main is arising from the pulmonary artery, and there is also evidence of pulmonary embolism.
Okay. Anything else? Anything else also? Anything in the LV? Do you appreciate anything in the LV also?
अब थोड़ा दोबारा इसको चलने दें फिर देखते हैं एलवी में भी थ्रोम्बस है क्या नहीं
Thrombus, yes. So many things together.
जी एक साथ बहुत सारी चीजें
So what is wrong with the patient? This is the 3D image of the CT image.
So now thrombus is very clear, Yusuf.
Yes, thrombus is there, anterior wall MI is there. There is subendocardial hyperperfusion also. So MI is there, pulmonary embolism is there. So all this in one case. This is again 3D pictures of the Al-Kappa and the image showing LMS arising from the main pulmonary artery. And the distal course of the left system is non-obstructive, no disease in the. So how did this patient had an MI? As far as the DVT embolism is concerned, there was a cause. There was evidence of bilateral DVT on Doppler ultrasonography. And another interesting finding was that before coronary angiography, patients' platelet count was very high, probably because of splenectomy. So where does the whole thing fit in? What explains the whole picture? What explains pulmonary embolism? What explains MI? Has anybody some idea how this whole thing can fit in just one pathology?
अयूब साहब ये हाइपर कागुलेबल स्टेट है ना तो हाइपर कागुलेबल स्टेट तो प्रोटीन सी प्रोटीन एस की डिफिशियंसीज वगैरह इसमें तो प्रेजेंटेशन होती है
Yeah, एक possibility उसमें तरह that is one possibility hypercoagulable state हो सकती है. Anything else? तो उसमें सब सारी जगहों पे इकट्ठे simultaneously हो गया clot.
तो
एक कमेंट यहाँ आ रहा है कि EFO तो नहीं है साथ में एसोसिएटेड
Sorry?
EFO तो नहीं है एसोसिएटेड साथ में
एको पूछ रहे हैं
Echo में severe hypokinesia था anterior wall का septum का.
I think MI तो बहुत क्लियर है इसमें और आप
MI is clear, yes, definitely is there. अच्छा इसमें I was also clueless, but Dr. Junaid came to help me, and he raised the possibility of a paradoxical coronary embolism. Well, I searched literature about the possibility of paradoxical coronary embolism, and though this has been described in cases with PFO and ASDs, but none case has been described in a case of Al-Kappa. But actually, this is a real possibility that the embolus, while traveling through the MPA, must have thrown some fragments into the LMS, and that could have led to the myocardial infarction. And
सॉरी आपको इंटरप्ट करूंगा इसमें तो पैराडॉक्सिकल नहीं हुआ बल्कि वो चूंकि पल्मोनरी आर्टरी से अराइज हो रही है आपकी लर्व सिस्टम
yes, from pulmonary artery to the LMS, and that led to the anterior wall myocardial infarction. And so this pulmonary embolism with paradoxical embolization to the LMS explains the whole thing. So there are some
embolism sir
sorry.
Ayub साहब could you call it paradoxical embolism because अगर ये जो है DVT से आया है और right atrium right ventricle then pulmonary artery से left vein arise हो रही है तो वो उसमें चला गया तो
चलिए उसको primary embolism कह लें, but whatever you call it, you name it. Otherwise, it is the same phenomenon.
सर जी ये एलवी क्लाट जो है ना आफ्टर एमआई इसको डेवलप हुआ है आप कहते हैं
जी
ये क्लाट जो है आफ्टर एमआई डेवलप हुआ है
LV Thomas, that was after MI. Yes. Yes, after MI. Dr. Dinesh is also here for his comments.
Assalamualaikum. Just for a quick comment, and then Professor Ayub sir will be proceeding. I'm an interventional cardiologist. Basically, this case presented to me. She presented with this extensive MI, and luckily they refused for a primary PCI. Luckily, because if it was a primary PCI, I was an issue. So the patient actually the first echocardiogram which I did was quite confusing for me. There was severe hypokinesia of this IVS apex and all distal anterior wall. But at the same time, the right ventricle was also down and it was globally hypokinetic. At that time, patient was quite acidotic, and it appeared to me that probably this was due to this shock. And since the lactates were quite high, I was thinking on the line of ketoacidosis and lactic acidosis. I thought that this RB dysfunction was probably as a part of overall poor cardiac output state. Then gradually, since the patient refused for a primary PCI, I thrombolized the patient. And after thrombolysis, the right ventricle started improving. The initial ejection fraction was 18%, and the last echocardiogram which I did a week ago, it was almost a normal left ventricular ejection fraction. So perhaps again there were two possibilities. Probably this was a clot migrating from the pulmonary artery towards the LAD, or it was simply a clot which obstructed the coronary, the pulmonary circulation, and then it dislodged after thrombolysis. So whatever the way, this was basically starting, the pathology started from the splenectomy, going towards hypercoagulable state, going towards DVT, the DVT dislodging, going the clot in the pulmonary artery, and then leading to STEMI as well as a pulmonary embolism.
So wonderful. So some of the points in this presentation are that L-kappa should always be suspected when you're not able to engage LMS, and when you see a huge megadominant RCA, that is a real possibility. So you will only diagnose L-kappa if it is in your mind. If this is not in your mind, then obviously you will diagnose. So always consider this diagnosis when you see big-sized megadominant RCA in the absence of LMS. And the second point is that coronary embolism is a rare cause of myocardial infarction. Rare things happen rarely, but they do happen. We must keep our mind and our eyes open. And the third point is that paradoxical coronary embolism may be suspected in patients with myocardial infarction when both things, when pulmonary embolism and MI occur together, then there is real possibility of paradoxical coronary embolism. Paradoxical coronary embolism. So these were some of the points. Thank you for the listening. And as I already said, that these images, coronary images, are courtesy Dr. Junaid Zafar, and the CT imaging was done at Al-Noor Diagnostic. Thank you.
Thank you, Dr. Ayub. Just a quick comment. Way back when we were starting 2D, passing the age of M mode, we had a case of MI, anterior MI, and ultimately when his angio was done, coronaries were otherwise clean, and he had left atrial myxoma. So a piece of myxoma going into the LAD, embolizing there.
Oh, that's right.
Yes. So things like that happen. So very interesting case in Kappa.